Thank you very much for the nice introduction. Yeah, so we kind of have a summary of where I've been and what I do right now. Yes, in addition to treating people with sleep breathing disorders and dental sleep medicine, I also treat people with craniofacial pain, temporomandibular joint dysfunction. Um, I started in 1976, um, and continued with sleep in the early 2000s. I don't drill teeth. I don't make dentures. This is really what I specialize in, and which is important to you and the patients. And just to focus a little bit on the last line. My model is to have convenient locations to wherever the patients may be. This is a patient-centric treatment, and it's all about getting referrals to allow patients easy access to care. And I tell people my philosophy of treatment is good medicine should be a right, not a privilege to those who can afford it or those that have the better insurances, but to really anybody that needs good medical care. And we try to make ourselves accessible. And at the end of the presentation, I'll talk about the insurances that we take, which is pretty much all of them. My medical insurance model is the same as yours. We're in network with most of the privates, Medicare, and so on. But we'll get more specific about that toward the end. So I've developed this presentation around three educational objectives. We'll start with the first one, which is an appraisal of the impact of sleep breathing disorders such as sleep apnea, obstructive sleep apnea, and there are others, primary snoring, upper airway resistance syndrome, people with high respiratory disturbance indexes. We're going to talk about that later. And the effect of these sleep breathing disorders on employee health and safety and productivity. So we'll start with this slide. And this slide is pretty intuitive. I don't think there's a great revelation here. It's from the AAA Foundation for Traffic Safety. And it kind of promotes what we would assume, right? Less sleep is going to increase the risk of having a car accident. So we may not know the percents. So if somebody's sleeping less than 4 hours, they have an 11.5% more likelihood of having a car accident. That'll decrease with the amount of time slept, 4 to 5 hours, about a little over 4%, 5 to 6 hours, almost 2%, and 6 to 7 hours, 1.3%. So, as I say, this is pretty intuitive. So why show the slide? So what this slide and what the study um, doesn't discuss is the quality of sleep. And that quality of sleep is going to be compromised with people who have sleep breathing disorders. And I have many patients that come into the office and say, Dr. Chase, I'm sleeping 6 to 8 hours, but I just lost my license because I had my third car accident where I fell asleep. And the hallmark of having a sleep breathing disorder is we have these fragmented interruptions, right? Patient goes into deep or dreaming sleep. They have an obstruction of the airway. They have an oxygen desaturation, and then they have an arousal from deep to light sleep. So their sleep is fragmented. And as we know, people can have various severities, mild, moderate, and severe, anywhere, 5 to 15 being mild, 15 to 30 being moderate, and over 30 being severe. And patients can come in having 20, 30 events an hour. And that's the issue. Patients sleeping 6, 7, 8 hours, maybe even 9 or 10 hours, and they can't make up the sleep by sleeping more time because each hour they sleep, they'll continue to have these apneic events. So we want to look at not only the duration of sleep, but the quality of sleep. And so drowsy driving causes crashes. And if we look on the right-hand side, we see the crash, right? This oil tanker has crashed into a car. The driver was deemed to have a sleep breathing disorder. But what I want to draw your attention to is what you don't see. All right. And if we look at the accident, the scene of the accident, we notice something that's missing. And what's missing is the skid marks. When these accidents occur, the driver is asleep and he never gets a chance to hit the brakes. Even if there is other accidents where the driver sees it coming, right, they hit the brakes, at least they're decelerating. But in these accidents, often they're more fatal and more serious because the driver is sleeping and there's no effort to at least break the momentum of the vehicle. So these tend to be quite serious and deadly. So this is from the American Academy of Sleep Medicine. I'm going to quote and reference some studies and position papers from the AASM, which is sort of the governing body in in medicine for sleep medicine. And again, the total in dollars of what we're costing our society and our country and lost productivity, comorbid diseases. We're going to talk more about that. High blood pressure, AFib, diabetes, obesity, motor vehicle accidents, and accidents in the workplace. And according to the National Sleep Foundation, they're up to 100 million people in this country that may have some sort of sleep breathing disorder. That's about a third of the population, so it's quite ubiquitous. And then they report that only about 10% of that 100 million are being diagnosed and treated. And then on my side, on the oral appliance side, which is my specialty, only about 5% of that 10% is getting oral appliances. So we have a silent or a hidden health crisis that really needs to be brought out in the open. And, these people are showing up in doctors and dental offices, but now it's incumbent upon us to screen them and identify their some level of disease. And we're going to be talking about that as we go along. So this is from the position statement of the American Academy of Sleep Medicine. And untreated, OSA is a potential lethal disease. Why? Because it's associated with hypertension, congestive heart failure, AFib, coronary artery disease, stroke, and diabetes. And, to my understanding, from the college and cardiologists that I work with, AFib and sleep medicine is a very bad, dangerous combination. Patients may have a 6 to 8 times more likelihood of having a stroke, right? We have an afibrillation, the blood backs up. We're taking the oxygen out of the blood during these events, and strokes are very prevalent in these patients with untreated sleep apnea. So, and the common symptoms, right? Excessive daytime sleepiness, which increases the risk of transportation crashes and drowsiness. But what's interesting is, I tell patients often the body doesn't follow the rules, right? So we accept we expect people with more severe disease, severe sleep apnea, to have more daytime sleepiness, and that's not always the case. I can have patients that have very mild disease, and we'll see a little bit later cases that may be undiagnosed with sleep apnea, but they have other sleep breathing disorders, and they're very symptomatic. Or we can have patients with very high levels of severe sleep apnea, and they have no symptoms at all. And sometimes they come to my office confused. My doctor sent me to you because I'm on my fourth high blood pressure medication, but they have no symptoms. I don't snore. I don't wake up tired or sleepy. I feel I get a good night's sleep. So we have to be sensitive to those patients as well. Um, so for 20 years, and I love this line, the National Transportation Safety Board has prioritized this issue by including it on the most wanted list of transportation safety improvements. I love that. It's pretty dramatic. And therefore, the diagnosis and effective treatment of OSA in transportation transportation personnel is an urgent safety, health and safety priority. And that's the underline and the italics of mine. But I think this is a very powerful statement, and this is referenced by the National Transportation Safety Board and the American Academy of Sleep Medicine. So continuing on, we have OSA leading to serious health and safety and financial implications. And the evidence supports identification, which is screening. And we're going to talk about screening because screening is, I think, a tremendously missed opportunity for us in medicine to identify these patients. CPAP or oral appliance therapy as a treatment. And the question mark here is my insert also, high risk commercial operators. And I think we should include everybody. What is a high risk? Okay, so maybe they're and driving tractor trailer trucks and buses in the city and and the trains and so on. But other people are at risk too. So we shouldn't discriminate on the people that we're screening and deny them possible treatment too, because this is affecting their quality of life. Um, and the current standard of care demands action to mitigate these serious health risks. And again, I put that star, which is my insert. And I like this statement, standard of care. Standard of care is really what we have to focus on. My understanding of malpractice isn't that we did something that didn't give the patient the outcome desired or um, the results that the patient was hoping for. Malpractice is, did we follow standard of care of our community, of the medical community? And in the dental office, standard of care when the dentist or hygienist gives an oral examination, standard of care is to screen for oral cancer, and it's also standard of care to screen for a sleep breathing disorder. And there are signs in the oral cavity that give clues to the dentist as to what those screening indicators may be. So, according to this health and safety report, almost 1 billion people worldwide, right? And that's almost a conservative number, and a lot of that has to do with the Americanization of the diets around the world. People getting more obese, we're living longer. We're going to talk more about that as well. But it's really a worldwide problem. Very, very high incidence in India right now and in the Far East. So these affected individual people who have these sleep breathing disorders and work under the influence of OSA symptoms significantly impairs their work productivity, right? This is sort of repeating ourselves, but here we go with the American Association of Railroads, um, trying to combat worker fatigue, including sleep disordered screening, right? And they're issuing a safety recommendation for railroads to screen and test for OSA in everyday life, and we have references about that. And here's this is recent, right? In 2016, we may have seen in the papers this crash in Hoboken for a commuter train, right? And federal investigators attributed this accident and the one in New York to engineers with untreated sleep apnea. And here's the one in New York, a derailed train, right? The engineer who operated this Metro North train derailed, killing 4 passengers and injuring dozens more, suffering from a sleep breathing disorder. And the investigation observed that William Rockefeller Jr., the engineer, had severe obstructive sleep apnea. And the officials in Utah have narrowed down the cause of a deadly Greyhound bus crash as a fatigue that took the life of a teenage girl. And this is tragic, right? Um, and that we should be screening for OSA, both self-reported, which is going to be surveys, and objectively measurable criteria, which we're going to talk about some home studies. And these are preventable, and I think that's such a key word here, that this doesn't have to happen. That if these people are screened, identified, diagnosed, and treated, and we're going to talk about treatment later, that these crashes are preventable. And, it starts with us because we're seeing these patients in our medical and dental offices. And then we need to educate, train, and provide resources regarding the role of fatigue and sleep disorders in transportation crashes. So I think we beat that up enough, and let's get to objective number 2, which is identifying the signs and symptoms of a sleep breathing disorder to promote early detection and intervention. So these OSA symptoms can develop gradually and be present for years before the patient is evaluated. And I'm going to say this a few times during this presentation, that people normalize their symptoms, right? So we have loud snoring, witness apneas, excessive daytime sleepiness. And I've had patients come in and say, I don't understand it. Everybody in my family snores. I snore, My parents snored. Everybody in my family snores. Snoring is normal. No, it's not. Snoring. I tell patients snoring is an indicator. It's an indicator that the airway is about to obstruct, right? And witness apneas. People tell me I stop breathing while I'm sleeping, and they're sleeping. They have no idea that this is going on. And I've had patients tell me nobody wakes up in the morning refreshed, energetic, jumping out of bed. Everybody takes a nap at lunchtime. So they're walking around with these symptoms for perhaps years, right? And we're adaptive creatures. We can try to create workarounds, but ultimately this is going to come up and get us. Um, and early recognition and treatment improves neurobehavioral and cardiovascular health. And I kind of underlined and italicized the neurobehavioral because it's going to affect cognition, not just our cardiovascular and physiologic health. Um, People will come in, and these are young people. They have a compromised memory. They're on the psychotropics for anxiety and depression. They wake up foggy brained. They have excessive headaches in the morning. Um, uh, it affects being clear-minded, learning, and so we have this interplay between REM sleep, which is going to affect the neurobehavioral issues, and slow wave deep sleep, which is going to affect more of the physiologic issues. And these treatments, as we're going to see, can significantly reduce cardiovascular risk, hypertension, arrhythmias. And what I tell patients, and patients appreciate this information, is when you have an apneic event, right? You obstruct, you stop breathing, so to speak, and you have an oxygen desaturation, and that triggers a sympathetic response, right? We have a release of epinephrine, we have a release of cortisol, and these events that are occurring 100, 200, 300 times, we keep having these little surges of epinephrine. We're not active, we're not burning it, and therefore we now have this increase in blood pressure, increase in heart rate, and it's going to have profound effects on our physiologic health. Now, I put this in about children, even though this presentation isn't about children per se. Um, but I'm fully convinced if we identify these children in an earlier, as or these patients as children, because children have pediatric sleep apnea, and as we said on top, the OSA symptoms develop gradually and present for years before a patient is found, and they're presenting as children. In fact, I read an article recently that identified ADD and ADHD may be reclassified as a sleep breathing disorder. These kids are sleepy during the day. They're oppositionally defiant. They have poor schoolwork. It's identified with bruxism and grinding their teeth at night and snoring. Children should not be snoring. And we have more children being obese today, with the diets that they have. So we not only have to identify these things early in adults, but we should really be looking at them, in our children. They're mouth breathers, they have chronic allergies, and they're not really thriving. And the thing about with children is they can be easily treated with orthodontics. And we have something called rapid palatal expansion, which can expand the arches, give more room for the tongue, help develop the lower third of the face, increase nasal breathing. And it's a lot better than for me seeing them as adults, trying to treat them with oral appliance, CPAP, or some kind of surgical procedure. So I just want to bring this to everybody's attention that we really should not only looking at our adult patients, but the young adult patients as well, the teenagers and 20-year-olds, because they are very symptomatic often, and even in children. So I kind of like the language of this slide. Screening in medicine is a strategy used to identify the possible presence of an as yet undiagnosed disease with or without recognized signs or symptoms. We really have to now ask our patients and look closely for identifying patients in the screening process. And it's apparently if a person's apparently in good health. I think about I read an article not long ago in one of the medical journals that there were 750,000 cardiac deaths last year. of which 150,000 were sudden cardiac deaths. And what was their first symptom? Death. It's that 30 or 40-year-old guy running around the neighborhood, two cars in the garage, a couple of kids in the house, beautiful wife, and all of a sudden he has a fatal heart attack. And if that person was at the physician, perhaps they were screened. Um, this is what we're looking for. He was apparently in good health, maybe not with very obvious signs or symptoms, but in the process of screening, perhaps we can save these people's lives. And I had a professor who used to say, normal does not mean optimal, right? So patients will come in and say, it's normal for me to be sleepy. It's normal for me to wake up tired. It's normal for me to take naps during lunch. It's normal for me to fall asleep 5 o'clock in, the afternoon in front of the TV. But it doesn't mean that that's optimal. It doesn't mean it's the way it should be. So one of my messages whenever I speak is that to tell my colleagues, do not profile or stereotype, whether they're older or younger, men or women, slim or husky. I had a patient the other day. She she was 67 years old. Her BMI was 19. And she comes in suffering from fatigue, insomnia, um, mental confusion, poor memory. And in the last 2 years, she was treated for mononucleosis, Lyme's disease, anxiety disorders. She was on Vyvanse, trazodone, and she was not getting better. Finally, somebody, I think the ENT gave her a sleep study, and she had severe sleep apnea. She had 32 events an hour. We made her an oral appliance and changed her life. She's falling asleep in about 12 minutes, staying asleep, maybe waking up once, waking up refreshed, energetic, and we're getting her off some of the medications that she's been put on. And I have that often. Young women will walk into my office in their 20s and 30s, and they're on all kinds of medications until finally somebody decides to give them a sleep study, and turns out they have some level of sleep breathing disorder. So again, it's not a disease of 55-year-old men who are overweight, lying on the couch with the TV clicker on their belly while they're taking a nap. We need to really expand our vision to include a greater variety of possible patients. And as we said before, we can have a very short four-question self-screener. Do you snore? Right? It's one of the major signs of a sleep breathing disorder. Do you stop breathing while sleeping, or awaken choking or gasping? And is it witnessed, right? And we use the word bad partner. We want to be politically correct. And often, yeah, they'll say, yeah, my wife, my girlfriend, my whomever, says I stop breathing. And it's freaky, right? They're often, the patient, the bad partner thinks they're dying, you stop breathing. And it's a pretty, it's pretty serious, right? Do you wake with headaches or feeling unrefreshed? And are you sleepy, drowsy during the day? And that's enough. That's going to identify the vast majority of patients just by asking these questions. And then some medical questions. Do you have high blood pressure? Well, I have so many patients that have early onset type 2 diabetes. They get this release of cortisol while they have these the sympathetic activation while they have these events. And my diabetic patients, they wake up in the morning, they don't understand why their blood sugars are high. I didn't eat until, since 6 o'clock last night. There's no reason for me to be high sugar in the morning, and they wake up and their sugar levels are high. And it's from the cortisol. And until they can address that sleep apnea, they're fighting an uphill battle. Do you have AFib? And are you overweight? And this is a big one. It's always a touchy subject with patients to discuss it, but it's probably one of the biggest uh, factors um, in sleep apnea, along with the age. We can't do much about age, but any weight is really going to compromise the effectiveness of a CPAP or oral appliance or any therapy we're going to do. And the purpose of screening is not to make a diagnosis, it's to identify candidates for sleep studies. And that's what we want to do. You're a candidate for a sleep study. I don't know if you do have sleep apnea. I don't know if you don't. but you're certainly a candidate for a sleep study. And sleep studies today are really quite easy to administer, right? We have on the top left, the watermark unit just sits on the forehead, a little cannula to measure respiratory effort. On the in the middle there on top, we have a ResMed effort belt with again a pulse ox and a cannula, and on the bottom we have a watch pad, which I really like. It measures what we call peripheral arterial tone, sympathetic discharging, and today, those units, this is an older picture. The units have become smaller and smaller. Many of them are disposable. And now we even have a ring, the Aura ring, which has been now accepted as a valid sleep study from the insurances. So this is a very easy process. Now, I did want to go through some of the sleep studies. I have two sleep studies. These are summary reports. We'll go through them quickly, but I think there's really valuable information on here to understand. So the first arrow that just went up on the left is a RDI. I know this one's a little hard to read. And that includes the AHI, the apneic events, plus respiratory disturbances. And I think, many of my physician colleagues pay attention to the AHI, but they don't really always discuss the RDI with the patient because these are the total respiratory events. And as we're going to see, sometimes you can have a low AHI, a high RDI, and have a very symptomatic patient. So you have an average of 25 events an hour. High moderate is the AHI with an AHI of 18, almost 19. And so these are the apneic events where they deset. Today we're measuring at 4% loss of oxygen. And then I like to discuss with the patient at what sleep stage that occurs. So here, the predominant a number of events are in REM sleep. And as soon as I see it in REM sleep, I know it's affecting their neurocognitive abilities. I'm going to ask this patient, do you have trouble with your memory, thinking, learning? Are you waking up cranky, irritable? And that doesn't matter on age. This could be a young person as well. Uh, And then as the arrow shoots up on that right side, I tell patients, okay, if you're losing oxygen, how much oxygen are you losing? So your oxygen goes up as a maximum of 99%. These are percent numbers. The arrow on the left that's kind of been sitting there, it descending to 86. And then the arrow that just came up in the middle shows where there's no event. So the blue lines, these little blue hash marks and blocks are the peripheral arterial tone respiratory events. Here's a block where there's no events. The arrow that just came up shows little to no snoring. The arrow that's been sitting there is the oxygen levels, which is what we want. This next arrow is the heart rate, kind of what we want when a person is sleeping in bed. And now we have a cluster of events. Snoring is increased, oxygen levels are falling, heart rate's increasing. And when I show this to the patient, this is a clear visual of what's going on. And I usually get the, oh my God, I had no idea, that this is affecting my heart rate this way. I'm losing this much oxygen. Um, they see the snoring, colors, and it's kind of profound, and these clustered events, which is really dramatic for a patient. And they get this. And this is, okay, how fast can you get me a CPAP? How fast can you get me an oral appliance? Now, I want to contrast that sleep study to this one. So this is a patient that is going to be diagnosed without sleep apnea, right? The AHI is a little less than 1, 0.9, right? So the doctor said, okay, you don't have sleep apnea, no treatment for you, except this patient is very symptomatic. And I get these patients all the time. And these are usually younger patients, let's say from 18 to 30 or 40. They're slim. And they say, I wake up with headaches. I can sleep 8, 9, 10 hours. I'm always tired. They often have the autoimmune diseases. And why? Because they have a high RDI, the respiratory disturbance index. They're having these arousals. And the way I explain it is, as the tongue is falling back and about to obstruct the airway. If we look at the numbers of the AHI, the RDI, they have about 9, maybe 9, between 9 and 10 events an hour. And again, this is a person that may sleep a lot of hours. and still wake up unrefreshed and sleepy during the day. Here, their events are in non-REM. So when they're in non-REM, I'm going to suspect more of the autoimmune diseases that's going to affect their immune system. Here we have the events, and you can see how many events, how many arousals there are, right? So even though they have an AHI of less than 1, right, they're going to be diagnosed without sleep apnea. They still have a lot of respiratory events. Look at all the times their sleep has been disrupted. And if we look at the oxygen levels, the person is still desat. This person is desatting to 86, just like the person in the previous sleep study, right? So what I tell people with these low AHIs is if you have fewer events, the events could last longer. And if you have a longer event, you're gonna have more of a desaturation, right? And if we look at the oxygen desaturations, you can see this patient, even though they're not diagnosed officially with sleep apnea, they have AHIs less than 5. They're still going to still have an oxygen desaturations and many events. And these people still need to be treated, not sent out of the office so you don't have sleep apnea. We still have to treat them on a symptomatic basis. All right, so let's get to the third objective, which is evidence-based treatment strategies. And I'm an oral appliance guy, right? This is what I do. Now, before I go further, because I'm going to make some comments about CPAP, we are all CPAP friendly. We want to promote CPAP. I know it's been called the gold standard of therapy. It works. People love it. If I have a patient that has a CPAP and they love it, they're staying on it. But we know there are issues with CPAP, so we want to have this friendly relationship. And one of the biggest ways that I work with CPAP is I'll work with a physician that has a very severe sleep apneic patient. Maybe they have an AHI of 40 or 50 or 60. But the problem is the pressures of the CPAP machine are very high, which requires the straps of the mask to be very tight. Maybe they need a full face mask. They're a little claustrophobic, or they have a beard. So we can make an oral appliance. What the appliance will do is open the airway and allow the CPAP machine to have less pressure, maybe bring it down to 4 or 5 or 6, and maybe give that patient nasal pillows with a very easy strap. So we do a lot of combination therapy. So we're very CPAP friendly. However, there's an interesting study. I had to read this twice to really understand what they were saying because it's kind of counterintuitive. And it's a recent study. It was published in September 24. And what the study is talking about is how do we predict if a patient is already treated with CPAP and if there's still a driving risk? So these are patients. The objective of the study is to say, okay, we have patients that have been given the CPAP. Are they still persistent driving risk? Over 5,000 patients, so pretty valid. And they're going to look at near misses and accidents and sleepiness at the wheel and SAW. That's kind of cute. Assess before and after CPAP use, and after is after 90 days. And here's the results. The sleepiness at the wheel under treatment, again, counterintuitive. We wouldn't have expected. It's associated with an 8-fold higher incidence of near misses related to sleepiness. And this is people under treatment, under CPAP treatment. 5-fold higher incidence of accidents related to sleepiness. So we have to ask ourselves, why is that? Well, because of compliance. And the study found in these 5,000 patients that the average was less than 4 hours a night. And if a patient is using a CPAP less than 4 hours a night, that is a significant predictor of persistent driving risk with sleepiness at the wheel. So the conclusion, right? CPAP adherence less than 4 hours a night is an easy asset marker, as assessment marker for persistent drivingness, sleepiness at the wheel. And I like to reference this study. This is called the SAVE trial. It's a very prominent study in sleep medicine, very well known, very well, highly quoted. It went on for many years. It was started in 2005, over 2,700 patients. It's a worldwide study. It was done worldwide, closed out in January of 2016. It says the largest, most ambitious clinical trial undertaken in sleep apnea. And their conclusion was that CPAP adherence in these 2,000 patients, over 2,000 patients worldwide, was an average of 3.3 hours. after a year. Lancet did a a review of the of this SAFE trial, and it found no cardiovascular benefits for CPAP and OSA because of the significantly reduced cardiovascular events in CPAP. Why? Because of the non-adherence, and that's where we get the Medicare guidelines for CPAP use: 4 hours a night, 5 nights a week. But then we have to ask ourselves, okay, that's nice. We're putting a patient puts on the CPAP mask for 4 hours. They get up, go to the bathroom, they sleep another 4 hours. They don't wear it. Let's talk about that. Um, now, this is an interesting statistic. This study reports, 46% to 86% of 83% of patients with CPAP have been reported to be non-adherent. And why the big discrepancy? And when I first started in sleep medicine years ago, I thought I was going to get all my patients from the sleep board physicians. And then I found out what the sleep board physicians are really good at is getting their patients compliant. And just like what I do, I'm an oral appliance provider. After I give that appliance to the patient, I need to make sure that they're wearing it. So we're calling that patient 2, 3, 4 days later. Are you wearing it? Are you having any trouble? And our protocol is to give every patient who gets an appliance a follow-up visit 3 to 4 weeks later to make sure it fits good, feels good, and they're getting some kind of benefit. And just in completeness, we see that patient for symptomatic relief over about 60 to 90 days. And then every patient, at least the moderate to severes, will get a post-insertion sleep study wearing the appliance to make sure that we get objective data that the appliance is working. But again, we have a high percent of patients that are not compliant because they're coming to me from, the PCPs, the cardiologists, the neurologists, and other physicians. And they're not CPAP compliant because the follow-up isn't there. With the sleep board physicians, they tend to be much more doting on the patient to make sure that they're adherent. So as we said, if that patient is putting on that CPAP machine for 4 hours, they're getting up to go in the bathroom, they're not putting it back on. What happens to that? And this is a study by Boyd, which I really, really like. And he talks about the effect of AHI. And if we look at the graph on the right, it says diagnostic PSG. So these are patients all diagnosed with severe sleep apnea, 30 events an hour plus. During the titration study, what we would expect, right? CPAP brought those numbers down, basically 10 or less. Very therapeutic. While they're wearing, and this is where the research was done, while they're wearing the CPAP machine, we get effective treatment. But once the CPAP is off, okay, that patient takes it off, the AHI shoots right back up to, moderate to severe. So what Boyd is talking about is if we average out the AHI over the night, yeah, it's a gold standard while the patient is wearing it, right? 4 hours a night, 5 nights a week doesn't really bring that patient to the medical standard that we want to create. All right, and this is called the SARA index. It stands for sleep adjusted residual AHI, and it forms some kind of calculation around what Boyd is promoting. That is, if we take the total sleep time wearing the CPAP and not wearing the CPAP over the total available time that the patient slept, we get a sleep adjusted residual AHI, and it's going to be higher than the treated AHI, depending upon what the AHI that the patient started with and how long they're wearing that CPAP for. So compliance becomes a really big issue. And these are studies done by Olivier van de Vieken, a good friend of mine. He's a head and neck surgeon in Belgium. And he's done studies comparing the effectiveness of CPAP with oral appliance relative to compliance. And his conclusions is that mandibular advancement device is comparable with CPAP effectiveness. Why? Because of the higher compliance of oral appliance therapy. So on the bottom, we see this little these two little graphs. If efficacy may be different, compliance may be different, but ultimately the effectiveness, total effectiveness, can be comparable. There's many studies. I just want to throw up one. The oral appliance therapy effectiveness of mandibular advancement appliances in treating sleep apnea. Conclusion, mandibular advancement devices reduce AHI, increase oxygen saturation, improve the symptoms. And there's many studies around this. It manipulates the soft palate, tongue, hyoid bone, so on and so on. So just one study to kind of set the tone. And talk a little bit more about oral appliance therapy. So we have a patient that normal breathing, lips together, tongue is forward in the mouth. And what the tongue does is the dorsum of the tongue sits against the hard palate, sort of acts as a stabilizing vector that prevents the jaw from falling back. And here we have an open airway, and here we have an apneic patient, compromised airway. And we have this head forward posture that creates this curve in the spine. And these patients, you can see them. They're walking around with their head forward. Their ears are in front of their shoulders. Their chin is tipped up. Their head is leaned back. But they have this, 14-pound head kind of cantilevered over or off their shoulders. And they always have backache, neck aches, shoulder aches. They're going to the chiropractor. But meanwhile, they have obstructive sleep apnea. Very often we'll put an appliance in a patient's mouth like this, ask them to stand up, and without prompting them, all of a sudden their posture improves. We have the little cartoon on the bottom where the airway is obstructed by the tongue. Here we have the silver thing in the mouth is the oral appliance, and the airway is open. And one of the things that I want to bring to your attention is this white arrow. And what we're looking at is that jaw is not advanced. The teeth are what we would call edge to edge. And that's a very important aspect. I'm going to talk about that now. So here's a guy that's looking at me. And as I'm looking at the patient, what I tell this patient is when you have an apneic event, your jaw drops back, the tongue falls back, and the tongue obstructs the airway. However, as you're sitting here right now, you're breathing and you're not snoring because you're holding your jaw in a very normal, comfortable position. Lips are together, you're breathing through your nose, air's going behind your tongue into your lungs. And all I have to do with my appliance is hold your jaw in the same position that you are right now while you're sleeping, preventing the jaw from falling back. And I tell that patient the big misunderstanding about what I do is patients, including many physicians and even dentists who think they know how to do this, they're moving the jaw too far forward. And the language is bad. It's called a mandibular advancement device, and it really should be a mandibular positioning device. The last thing I want to do is advance that mandible. And I'll show you in a few slides ways I can make an appliance with various modifications so we don't have to move the jaw forward. And if I don't move the jaw forward, I'm not causing side effects. So I'm not putting pressure on the TMJ. I'm not moving teeth. I'm not changing bites. I just want to fix the problem without the side effects. This is actually a patient of mine. I have a CBCT in my office, cone beam tomography. Without the appliance, the patient is obstructed. He has a closed down airway. You can see the position of the tongue. And it goes, we call it the VOT, velopharynx, oropharynx, tongue, and epiglottis. And here's the patient, same patient with the appliance in. And again, you can see that the mandible is not really advanced. We've opened the bite a little bit. The tongue is able to come forward. We have an open airway throughout the the entire oropharynx. Same patient, compromised airway with the appliance. The airway is open, and the airway opens not only AP, but it opens concentrically. So we get lateral opening as well. We'll show this
I
quickly.
have to say that this device has changed my life dramatically. I really can't believe how great it works. My wife has reported that I have no more sleep disturbances, no gasping for air, no snoring. I am quiet all night. I seem to have a little more alertness in the day. I've made it through movies in the evening, which is unusual for me. And I have been comfortable with it. My mouth seems to be adjusting to it. And I can't thank you so enough for creating such a fabulous device.
All right, so we'll thank him very much. And again, I have many testimonies like that. So we just showed one. And the other misunderstanding what I do is that people will think that the oral appliance is not for severe patients. Severe patients need to start on CPAP. There's no question about that. They should not have oral appliance first. Some patients will deny it, the CPAP machine, but really they should try CPAP first. But here's a 63-year-old patient with AFib, high blood pressure, BMI of 36. He had a split night study on the diagnostic portion. He had an AHI of 93, we'll call it, desatting to 68. And then on the bottom, that last paragraph is the treatment with CPAP, his CPAP numbers, and CPAP got him down to 37. And we made him an oral appliance, and we got him down to 10 events an hour. And he was very, very happy about that. And I got a very, very nice letter from his pulmonologist, sleep order physician. And I can really customize oral appliances. These are many appliances you're not going to find in the normal dental office. And I'll just point out two features. One is what we call nasal dilators. They're little, we call them little headlights or little buttons that sit under the lip at the alar of the nose, and it opens the nasal valve or prevents nasal valve collapse. We do a Cottle maneuver as part of our examination. We test the collapse of the nasal valves, and these nasal dilators work really well to increase nasal breathing. And then we have these little tongue buttons. These little tongue buttons sit under the tongue. And I tell patients it's like if you got a pebble in your shoe, your foot will pull away. So as we put these little tongue buttons under the tongue, patients don't even know they're there, but it kind of stimulates the tongue to come upward and forward, and that's what we want. And these are little techniques that we've developed so that we don't have to over advance the mandible. In this middle picture, you're standing on the tongue, looking forward, and then the picture on the right, you're looking at the patient head on, and this is William with his appliance, and this appliance got his AHI from 93 to 10. My other specialty, as I said before, I treat people with craniofacial pain, TMJ. On the top row, these are TMJ appliances with patients repositioned. And it's similar to what we do with the oral appliance. In the middle, there's an appliance in the patient's mouth. Um, and I want this patient to be able to close her lips. Nobody should even know that she's wearing it. And again, you can see the mandible is not advanced. The picture on the bottom right, you can see how small it is, a different style, different material. But the picture on the left shows something called the DentaTrack. These are compliance chips. And for people who work for the MTA, we have pilots, their unions want us to be able to track compliance, right? Is the patient wearing it? Compliance, we're banging away that this is a very important factor. So this is a compliance report that we can create from this chip. So this patient, you can see, wore from November 19th through for a month to the middle of December. And you can see clearly he forgot to put it in one night. Maybe he was sleeping someplace else, who knows? But this is the data that we collect, and we can create a hard copy. We can fax it. We can email it. We can do a electronic email. So these compliance reports work very well. And here's the data. And then, I tell patients we don't even have to take the GUI impressions. We have a digital camera, so we don't have to use the big trays and all that GUI stuff. And we have a digital camera. The red arrow is pointing at the wand. We just take pictures of the teeth and tell the patient these images are just like their phone. It's digital, comes up on the computer, and I have digital computer assisted design software. We can design the appliances, and I can create anything I want. So I can make them small, comfortable, and that's what patients want. I tell the women they're very petite. You can put it in your mouth. Nobody would even know you're wearing it. Easy to travel with, obviously. Many patients who fly, they wear them on the flights. They're not snoring. They're waking up more refreshed wherever they're ending up. And really, it's a fantastic. People are really happy to get them. Here's the image after the photos are taken. And why are people having more sleep apnea? One is they're living longer, right? Not much we can do about that. Um, but we're also getting heavier, right? So the projection is by the year 2030, the obesity in this country is really out of control. And obesity comes with a lot of medical comorbidities. And we'll contrast that into the 1980s and early 2000s. And you can see not only not the rise in obesity, but how quickly, you know, the diets have changed. And then our sleep hygiene, right? Um, so Thomas Edison really screwed up our sleeping by inventing the light bulb in 1879. 1910, people was getting around 9 hours of sleep. That decreased by 1975. Then we have the internet coming on board in 1983, and people on their laptops, and now the iPhone in 2007. We're certainly going in the wrong direction with our electronic devices. People picking them, they're waking up at night and picking them up, and who knows what they're doing. So, ubiquitous problem. Again, this is the last slide that I have, and it talks about the medical insurance that we participate in. We bill mostly in network, and it's just like what you do. I have my own billing department in our staff, where it's Aetna, Cigna, the Blues, Anthem now, Empire, and so on. And we're a Medicare provider. Uh, and we accept Medicare just like everybody else. We do some managed care plans, some community plans. We're on Health First, GHI, the unions, and so on. So, as I said in the beginning, we want to make my therapy, oral appliance therapy, accessible to people, not only logistically by having many offices dotted around all the boroughs, Long Island, including Westchester, Yonkers. But having a medical insurance model. So we're a few minutes before 10 o'clock. I wanted to leave a couple minutes for some questions. I know we went through this very quickly. I spoke very very quickly, which is unusual for me because I have kind of a laid back personality. But I wanted to get through a lot of slides very quickly, and I hope it was valuable. I hope I brought some attention to this issue of sleep breathing disorders, occupational medicine, and transportation. And I thank you very much for your attendance and attention.